Well, I'll give everyone an introduction. Camille Charlier is our pilot grant coordinator for the next 10 days. We've got Renee Clark, who's going to be stepping in and helping a little bit with pilot grants, especially human subjects studies. Shruti is our administrative assistant, program assistant, I think, actually, and she helps with the professional development core and the pilot core. Susan Crayne is on, she's our grants specialist, grants management specialist, our grants administrator. So she helps with a lot of pre-award and putting together applications ready for NIH. Joan Lukowskis, who is our director of proposal development and now also co-director of the professional development core, is on. And we've got Tanya Moran, co-director of the Clinical Trials Center of Excellence, on as well. And I'm gonna share my screen and I'll let Susan take it away. Let me just make sure I've got the right screen shared.
Looks right.
Okay.
Okay, so hi, I'm Susan Crayne, and like Megan said, I'm the grants administrator at the CTSI, and I wanted to talk about budget justifications, specifically the detailed budget justification when you're submitting to NIH. There are two common types of budget justification to NIH, the detailed, which is what we're going to talk about, and then the modular budget justification, which is really just a personnel justification. So the budget justification is sometimes called the budget narrative, and it's just an explanation of the costs in your budget. And you want to put it in a narrative form and clearly explain your costs and how they're calculated and why they're necessary to your project. It's a very essential part of your proposal because it helps to show that you've thought about your budget clearly, and it helps you to know how much what you're proposing is going to cost. So you want your budget to be reasonable and thoroughly thought out, and follow any guidelines that are given in the RFA, and keep in mind that the people who review your budget not necessarily are familiar with your project. Some of them are just grants people or budget people like me, and so they will be looking at your budget justification to clearly see that you've justified what you're asking for. So next slide. Okay, so again, a thoroughly detailed justification helps to show that you've put thought into your project. And so you're going to want to have a complete and realistic justification that will also help to minimize chances that when they try to cut budgets, if your budget is thoroughly justified that you need what you say you need, then it might help to reduce the chances that your budget categories will be cut upon funding. Sponsors really do have a good idea of what a project should cost, and so they can tell if things are budgeted over what they should be or under budgeted. And of course, always read funding announcements for guidance. Sometimes they have specific things that they require to be in the budget, like travel to a sponsor meeting or so forth that they expect to see there, but they also have a lot of other great information for your overall proposal. So always read your funding announcement. These are the required components of the R&R, or research and related budget, that we're going to talk about a little bit in depth. Next, okay. So your senior and key personnel, these are your people who you're going to have bio sketches for, and these are only WVU employees. And this would also only be the state portion of their effort. And what we're going to see here. The UHA portion, if they're clinicians, we'll go and we'll see that later under other direct costs. But for key personnel, you're going to want to highlight a little bit about them, talk about some of their expertise and why they might be a good fit for your project and what they will do with regards to your proposal. And we'll put in calendar months and the years that they'll be working on the project. The other personnel, this is where you have like clinical research coordinators, lab assistants, those types of people. Those also would be your graduate assistants, student workers, that sort of thing. And you would again talk about what you need them to do for your proposal. And then the fringe benefits is just our rates here at West Virginia University, and it's kind of a standard little language there. Equipment, a lot of people send me things when I'm doing their justification and they say they need laptops. Laptops really aren't equipment defined by the NIH. So equipment is a unit cost of $5,000 or more and a useful life of at least a year. So for these bigger purchases of equipment, we would require some quotes and explaining why you need this piece of equipment. And if it's not going to be dedicated to the project, you have to sort of justify how it's going to be split and give a good rationale for that. Next. Okay. Travel costs. A lot of times I get travel costs and not so much detail, but NIH really does want to see who's going to travel, where they're going to travel, and how much it's going to cost and be broken down. And so in this example, we had this American Association for Cancer Research conference. I went to the website and they had meetings out for the first 3 years of this grant proposal, but the 4th year, they didn't have anything. So I based it on historical rotation, knowing that the 4th year would probably be somewhere in the West Coast. And you can see that I justified that. So each year I went through where it was going to be held and did all the costs for travel, who was traveling, where it was going to be, rental car, fuel, hotel, all the things, and told what my source was for finding the information. So it's the government standard rate for the lodging. And next slide will show you, oh, well, maybe not. The next slide was going to show you the flights. Oh, that one must have got moved, but I usually put in like when I looked up a Google flight because you know flights change. So anyway, next slide. Other direct costs, these are materials, consumables that are less than 5,000. So blood collection tubes and those sorts of things. And again, you'd want to kind of put in how many you need, what they're required for, prices per unit, and that sort of thing to give good detail. Office supplies really need a lot of good justification because a lot of that can be really considered your F&A should provide you with paper, right? So, but if you need to do a survey of, 5,000 people and it's a 20-page survey and you have to mail it, then you might want to have paper in your justification and in your budget. So good details there help to make sure that you're not going to get cut in that category. Next slide. Other direct costs could be equipment, maintenance service contracts, those types of things that are needed to cover any equipment that you have in your project. Again, good detail is often not given for these, so we want to make sure that we have some good details. Software, if you need licenses for specific software, again, a good rationale as to what that software is needed for and how many licenses and so forth. And this is where you would put your human subjects payments broken down by how many subjects, how much they'll be paid, how many times they'll be paid, and that sort of thing. Again, this is also where we would put the clinical component of the UHA salary for the clinicians. And any hospital employees would also go in other direct costs. Next slide. Consultants. Consultants have to be outside of WVU unless someone at WVU has an LLC that they do consulting, you know, on the side, which is not often the case. WVU employees do have to have effort, but if you have outside consultants, we would list those here with their name, describing what they're going to do, including their days, their rates of compensation, and how many, you know, when they're going to work, which years they're going to work on the grant. And all of that information must also be included in a letter of support from the consultant that will go in the letters of support section. Subcontracts, if you're working with another institution or some sort of organization outside of WVU, we would list them in your justification, and they would also have their own budget and justification that would be uploaded as well. And typically these need to come, I like them personally, if we're working with another institution, at least a week before the internal deadline for our submissions, just to make sure we have all the pieces. But we'll want to definitely have identifying their key personnel in there and their scope of work, and again, all their documents. So next slide. And I think that's the end of mine. Is that the end of mine? Yeah, these are your pilot program. Is that right, Megan? Did you want me to talk about these? I can't hear you. You're muted, honey.
Sorry, there we go. Thank you, Susan, for going over all of that. Everything that Susan described would be the same for our internal pilot mechanism. The only differences would be that indirect costs, those facility, the FNA costs, aren't allowable on a pilot grant because it is internal dollars. We also have a couple additional restrictions. Student stipends can't be charged to our CTSI pilot grant. And we really don't want our pilot grants to be used for bridge funding. So if you had an NIH grant of some kind, wasn't renewed, and you're starting new work, and this would just keep your staff or your lab employed in the interim until you get your next grant. There's bridge funding available through the Office of Research and Graduate Education, but pilot projects should really be for new and novel ideas that will generate new external grant applications. Some other things, we do allow PI salary on our CTSI pilot grants. This was kind of new about a year and a half ago. We added in this allowance, and up to 10% of your budget can be utilized for PI salary and fringe. So that doesn't equate to a lot for a $50,000 project. You can use $5,000 of that to cover PI effort and fringe, but it's kind of a good faith investment that we are making, hopefully to entice more clinical departments to see that we're, hoping to help. But certainly with a $50,000 pilot grant, most faculty's salary would eat up the budget with very, very little effort. So we want the money to go to materials and supplies, equipment, participant costs, etc. We also limit, because it is, a pilot grant, publication costs to $1,000 and conference travel to $2,000. So we think that this is reasonable, given that it's a one-year project, that's what we've kind of set up for those. So we're going to transition now to talk about human subjects and clinical trials considerations. So happy to do that. The first thing you want to think about when you're thinking about your human subject study is whether it qualifies for a clinical trial or not. A couple years ago, the NIH expanded and clarified their definition of a clinical trial, and they have these 4 questions that help you determine whether it is a clinical trial or not. In the past, I think people kind of thought of clinical trials as specific to drugs or devices, but really now it's expanded to include biomedical, behavioral outcomes. There might be anything where you're introducing a new intervention to somebody and you're going to be measuring a health outcome related to that. It now meets the definition of a clinical trial. Because there can be some gray areas and a lot of questions related to it, the NIH has a website totally dedicated to case studies of kind of gray or questionable clinical trials and what meets the definition or what doesn't. I can't tell you how many times I've referenced this website, and people on our team have referenced this website to kind of make the determination, because there are a lot of things that we can talk ourselves into or out of related to it being a clinical trial. And I will say there's really no disadvantage to taking the jump to your project being a clinical trial. We've had some investigators, I think, really timid and scared to categorize their human subjects research as a clinical trial. And, you know, there's no disadvantage to it being a clinical trial. There's, you know, some additional paperwork that's needed to be completed. But really, the safety of human subjects is the most paramount part of this, and all it's going to do is make sure that your human subjects are treated ethically and responsibly. So don't be intimidated by it. We've got a lot of personnel and staff available to help with clinical trials, whether it's determining whether it's a clinical trial or not, giving templates and examples. There's staff available, regulatory support. So please don't be intimidated by that, but I'll just put that out there. I'm going to dive into the specifics of what is required for our pilot grant, which is also really in line with the NIH. But I did want to take a moment to kind of highlight that CTSI, as well as the Clinical Trial Center of Excellence for all clinical trials, expects to see a protocol. And a protocol is different than what would go into the WVU-KC IRB questionnaire. So for people who are new to the WVU, this may not be a confusion, but for some of the people that have been around for a long time, they have the misconception that what goes into the IRB system, that KC software, is the same as a protocol. And it's just a little different. Much of what is asked in the WVU-KC system would be the same types of information that you would have in a protocol. But a protocol differs in that it's a single document that is a detailed plan of the study that would allow anybody on your study team or an auditor, an external person, to pick up this single document and be able to replicate your study following the same protocols and procedures. So Dr. Hodder, who's the Associate Vice President for Clinical and Translational Science, is a huge believer, as are our co-directors of the Clinical Trial Center of Excellence, that all clinical trials should have a protocol, and it should be similar to what you would expect in an industry-sponsored study. We strongly believe, and I think evidence shows, that there's less protocol deviations. Patients are treated, or participants are treated, in a much more equitable way. And I think it really helps from the NIH perspective and publication standard as well, that the studies are more easily reproduced and are reliable and valid in the study, because there's less dispersion or deviations from the original protocol. So I kind of talked a lot about this, the protocol's purpose, but it's a roadmap for the study. It should include everything from recruitment, how you're going to randomize participants, the delivery of the intervention, when reports are due, when you're going to do testing, when follow-up testing should be. If for some reason a participant can't make their study visit, is there a window for when a next visit could be? And some advice would be to really think about the protocol as if you were enrolling patient 0 and everything that could happen from recruitment to their very last visit and closing out the study. So go through the flow of the study, and it should help to develop your protocol. So this is sort of a screenshot of what the NIH system would look like For the CTSI purpose and our pilot grant purpose, or the research scholar, any internal funding mechanism, we obviously don't have you submit directly to the NIH, and it would be really complicated for our IT staff to build sort of a system that would allow you to mimic exactly the NIH system. So we've created a Word document that's linked to in our RFAs that follows these exact questions. So I'll talk a little bit first about section 2, which covers the conditions or focus all the way up until your inclusion and enrollment report. So the condition or focus is at least 1, but up to 20 entries are allowed to describe the study that you're going to be conducted. You really should utilize the MESH terminology for standardization, and exactly what you put into your study protocol would then correlate with your clinicaltrials.gov record. So it's pretty standard and easy to understand. The eligibility criteria, again, this would likely be like a copy and paste from your KC or your protocol, but it's a fill in the blank up to 1,500 characters. That should also mimic exactly what's in clinicaltrials.gov to describe inclusion and exclusion criteria. They prefer a bulleted list. I think it's easier for us as well, and reviewers if it's in a bulleted list. Continuing with section 2, age limits. Again, this is a pretty self-explanatory thing, but it's available in units of time from anywhere from minutes, if you're looking at newborns, to months, weeks, years. And it sometimes, you know, upper or lower limit of age inclusion is not required. NIH really over the past several years has really seen that when you're thinking about a clinical trial, you should operate from the perspective that anyone who has the disease or condition that you're studying be included in your study, and then only for very well scientifically justified or ethical reasons should they be excluded from your study. So just because it's convenient or easy or some other way to think about your study, you shouldn't necessarily exclude somebody based on their age, which definitely segues into the inclusion of women, minorities, and children. Just as I was saying before, you should operate from the perspective that everyone should be included in your study unless scientifically or ethically it's unreasonable for them to participate. So the headlines for the inclusion of women, minorities, and children, you would want to give a little bit of information about why both genders are included or not included, and it should be scientifically appropriate. The only time a gender should be excluded would be if the research question is relevant to only one gender, or if prior research strongly suggests that there is no gender difference. It wouldn't be ethically reasonable to repeat a same study if there's previously been found no evidence that there are gender or biological differences. If there's data that exists for the excluded gender, you also wouldn't need to do this. Let me see. Also, if you're studying prostate cancer, you don't need to include women in that study, or vice versa. If you're looking at ovarian cancer, there would be no need to include men. I would say too, with today's climate, not to forget males or females assigned at birth. So thinking about considerations for transgender populations, I think that will be something that goes forward in the future and should be included in your study as well. We've seen studies in the past where there's been confusion then when somebody who is transitioning or has transitioned wants to participate in a study. So think about that ahead of time. And children, for the NIH definition, is 18 or older. And as I mentioned, children should be expected to participate in clinical trials unless there's scientific or ethical reasons for them not to be included. Section 2 continued. Your recruitment and retention plan, this would be an upload or a fill in the box for our purposes, but this should describe how you will recruit and retain participants. You want to think about how you advertise your study, how you're going to generate and recruit participants in the study. If there's things that you want to take into consideration for culturally sensitive recruitment, you may want to think about that ahead of time. So strategies for how you might recruit in an urban setting or a city setting might be significantly different for how you would recruit in a rural setting, or if there's health literacy issues, you want to make sure that you're developing recruitment materials that will engage everyone that you want to recruit, and that recruitment will not just happen, you know, in a single area. It wouldn't necessarily be wise to recruit, you know, for example, at the WVU library and nowhere else. You're going to get a very narrow population of participants that would join your study. So think about creative ways to recruit for your study that would touch all different socioeconomic participants. Recruitment status, this is pretty self-explanatory, but here are the categories that the NIH lists and what we would accept. So there's not recruiting all the way to terminated or withdrawn. Typically, if you're submitting your new grant application, your enrollment or your recruitment status wouldn't be some of the later ones, but you may already have a study that's recruiting and you're building upon that. Your study timeline, this is something that I think is critical for grant applications and clinical trials and human subject studies in general. The study timeline isn't going to be specific dates. We don't want to see that you'll enroll your first participant necessarily on August 1st, but should maybe be detailed based on the month of the award or the quarter of the award. And it could be a diagram or it can be written text. So that's the study timeline. And then the enrollment of the first subject, this actually is a date that they're looking for, but it could be your actual date or a targeted or anticipated date. This is the inclusion and enrollment table. So this is what, when you're applying for a grant, you would complete, excuse me. A planned enrollment table. This may have changed a little bit. I didn't pull the brand new form, but this is what we're using internally for right now. And I don't think there's a lot of changes with any new forms from the NIH. They just released new forms last month. But your planned enrollment should be consistent with the demographics that exist in your recruiting areas, the sites that you have access to. So with most West Virginia studies, you know, we're not going to have the same diversity that you might have if you were conducting your study in California or Pennsylvania or a more culturally or ethnically diverse state. So with your justification, you'll just want to indicate that these are the demographics that exist in West Virginia, and that you'll do your best to recruit as diverse a population as possible, but that is a limitation of some of the research in West Virginia that probably about 90% of your participants will be white, non-Hispanic. I always look at census data, like if you were conducting your study and pulling a lot of participants from Charleston, West Virginia, you could expect to have a more diverse population. So look at the counties where you're going to be recruiting from primarily and adjust accordingly. Moving on to the protection of human subjects. So this starts with section 3, and it's section 3.1 is the protection of human subjects, which is sort of a lot of the meat of what would be in an IRB protocol and what should be included in your study protocol. So there's 4 parts to 3.1 of human subjects. 3.11 is the risk to human subjects. 3.12 is the adequacy of protection against risks. Next is potential benefits. And 4th is the importance of the knowledge to be gained. And this really helps reviewers and you as the study PI and others to really think about, is this an ethical study? And have I thought about, should this study be completed the way I'm designing it? And what's gonna come out of this? And so that's why I think earlier when I touched on that, you know, when you're considering both genders, if studies that have been done previously already prove the point, it may not be worthwhile to do this study. So that's where you'd kind of flesh some of this out and weigh, you know, whether the study should move forward or not. If you are doing a human subject study and it's not a clinical trial, then yay, you're done. But if it is a clinical trial, we'll continue on. So moving on to 3.2, some of these are pretty easy. Is it a multi-site study? So are you collaborating with other institutions that will be following the same protocol? If so, then it is expected from NIH guidelines and WVU's guidelines that you'll use a single IRB. So there's smart IRBs out there. Some of our organizations have institutional agreements with respect that they will honor each other's IRBs. This isn't hopefully a super complex thing, but I think from the NIH perspective and our perspective, operating under the same IRB and making sure that everybody has considered all the same things and everything is detailed for the study allows to make sure that the study is being completed the same at each site, and there's not different expectations at each of the different sites. Your data safety and monitoring plan is required for all clinical trials. And so this should really reflect how complex or how risky your study is. So it should be an overall framework for how you're monitoring the safety of the participants. You would want to think about stopping rules. So, you know, if you get 10 or 15 or 50 participants in, and there's a lot of negative consequences, you would want to think about calling off the study. And you may work in consultation with a data safety and monitoring board who will help you make those decisions. So those kind of go hand in hand. So you don't necessarily have to have a data safety and monitoring board for our internal mechanism. We certainly encourage you, or at least to have a medical monitor appointed, but you would describe that in your data safety and monitoring plan. You don't have to, you would want to go over sort of who will be the medical monitor, who will review your data, things like that in that plan. And in section 3.5, the structure of your study team, this is where you would describe not only your study team, but if there is a data and safety monitoring board, you would describe them there. You'd give an overview of each of their roles and responsibilities. If there's various sites, you describe what each of those sites would be doing. This can be a combination of text and diagrams, and I would encourage you to sort of have both of those when you upload this into the document. Moving on to the protocol. Section 4.1 is a brief summary. So this is up to 5,000 characters, and it should be a short description of the clinical trial study, including a statement about the clinical study's hypothesis. And the language used in this section should be so that the lay public can understand this. The narrative and study description, which is 4.2, which is also an insert box, and this is up to 32,000 characters, is a narrative description of the protocol. So if you develop that protocol as a separate document, you'll be able to use this. The narrative study shouldn't necessarily be a copy and paste of your research strategy, which is separate and different from the clinical trials considerations, but some of the same information may be present in both of those. Importantly, you should describe plans for assignment of participants if there's multiple study arms, how you're going to deliver the intervention, talk about the methods, how you came up with the sample size, what data analytics you're going to run, and make sure they're appropriate. So that's the narrative study description. Moving on to the primary purpose, this is a long text, but basically this is a drop-down menu for the primary purpose of your study. And so it's things from treatment to diagnostics to basic science, device feasibility, and there's the definitions here for each of those. So I won't read them to you, but the slides will be available and this recording will be available as well. 4.2C is interventions. Again, this is another drop-down, but here are all of the options that are interventions that the NIH has thought of. Of course, they leave the option for other at the end, and if you select other, you would describe it below. But hopefully pretty much everything that you could think of is included in this list. Section 4.2D is the study phase. Again, this is a drop-down, but I gave the definitions. So the NIH actually breaks things down almost in half integrals from early phase 1 all the way to phase 4, but you can see that they've got phase 1/phase 2, phase 2/phase 3. So there's lots of options for this, and these are their definitions for how you would categorize the phases. Intervention model, this is another drop-down. This is the strategy for assigning your participants. So there's availabilities for single group, parallel, crossover, factorial, and sequential. These are the types of things that you would discuss in detail with a biostatistician or a study clinical trialist ahead of time when you're designing your study. So you'll think about how your intervention will be delivered. Masking is the same thing as blinding. This is another thing that will be reported in clinicaltrials.gov. And there's different types of blinding or masking. Sometimes the participant is blinded, sometimes the care provider is blinded, sometimes it's the investigator, and sometimes it's the assessor, sometimes it's a combination of those, all of them, none of them, or anything in between. So you would just mark yes or no for each of those 4 categories of whether they're blinded or not. And then allocation is whether it's randomized or non-randomized. And again, this is a strategy that you would really want to think through when designing your study and working with a biostatistician or study design clinical trial expert. Moving on, your outcome measures. This is how it looks in NIH. There's boxes on there's a table included in our Word document for the internal funding opportunities. And you can have as many outcomes as you would like. Of course, you need to at least have one outcome, and that would be your primary outcome. But you'll also have secondary or tertiary level outcomes. And you're going to describe what the outcome is that you're looking at, the time frame for when you'll study it. Is it at baseline in 6 weeks from there? Is it only post-intervention that you're going to look at that outcome? And then a description. And the description is really where you'll talk about the metrics or the tests that you'll use to characterize that outcome measures. A lot of outcome measures are clinically based, but if you're looking at some type of behavioral intervention, it might look a little bit different. I will say and caution for sure that you want to be really considerate when you describe what your primary and secondary outcomes are, and that your study is powered in such a way that you'll be able to make statistically significant or statistically evidence-based outcome decisions. Because everything that is listed as an outcome measure must then be reported on clinicaltrials.gov. So if your study isn't powered to examine something, don't include it, because you won't be able to report it ethically in clinicaltrials.gov. Moving on with section 4, which is the last section, is your statistical design and power, section 4.4. This is an upload. Typically it's anywhere from a paragraph to a page and a half, and you would work with the biostatistician to think about how you've powered your study and how you've designed it with a statistical plan. Your subject participant duration, this is just sort of a fill in the box, but it's how long each participant would be included in the study. They want you to indicate whether it's an FDA regulated intervention, yes or no. And then the last thing is your dissemination plan. So with NIH funds, with CTSI funds, I think really with any granting agency, they want to make sure that you're sharing your results after you've completed the study and analyzed the results. So of course you want to put it into clinicaltrials.gov if it's a clinical trial, but you also probably plan to publish it. And so you might describe which journals you would be targeting. If you're planning to present it at a national or societal meeting, talk about the meetings that you'll share this information with. Some studies have community advisory boards or have a large impact for the community. So think about how you might get this to your community of interest, whether it's fellow providers or researchers or the community that you're studying. They want to hear about how the study turned out, and if there's something practical that maybe that city or town or health system can implement to carry on the work and further the study. I've included some contact information here. My name is up here. Shelly and Tanya are up here as well. I would have included Camille, but she's with us for 10 more days, so her name's not on here. It's not a dig to her, but just in the long time she'll be on to different things and probably won't want to hear about your specific pilot questions. And then Susan Crayne, who is a wonderful, wonderful resource for putting your grant application together for internal mechanisms, but we really try to utilize her for external applications on a bigger scale. I've included a few resources, and I can include a few more before I distribute these slides, but I'll stop sharing and just see what questions, if there are any questions from Dr. Mala or anybody else who joined from the CTSI team.
I'm going to ask a question related to the budget preparation. So in terms of budget preparation and I'm doing it for my recent grant submissions, one of the common questions I'm coming across is tissue bank access and the expenses related to it. And they also note that the price for a technician to access the samples to do the slides, given a certain X number. So when I try to include that, since I don't know how many hours are they going to spend to get the data that I need, how would be a better way of putting that in the budget justification? Just leave it like, X amount of dollars per hour and say total amount, or how would be a better way to put that in?
Yeah, if you don't honestly have an actual number of hours, you could, estimate, how many hours it might take. Would this person be someone here at WVU?
Yeah, in the path lab.
Yeah, so we would just do a percentage of their effort. You wouldn't have to put hours in for that. So, if it's not going to take that much time, maybe it's 5%. If you have a large study and it does take somewhere a good amount of time, it maybe could be 15, 20%. I mean, we would just kind of estimate effort wise. Does that make sense? And you would just describe what they would be doing in relationship to your proposal and just a percentage of effort.
I see. Okay. Yeah, that makes sense.
The Path Lab might also have some standardized fees associated with it, and I would encourage you to talk to Jim Code or Bill Petros and describe your study, and they probably have done similar things. And so if you know that you want to look at 50 tissue samples and whether they're in paraffin block or not, whether they're fresh or frozen, they would be able to give you a better, I think, estimate of how much time it would take. So even if they've not carried out your exact study, they could make some estimations, and you would include that in your budget justification there, that based on similar studies on the type of tissue and the number of tissues needed, here's what we expect. And I think they would both be really happy to help you think through some of that.
Okay, that sounds good.
Mm-hmm.
Thank you.
Of course.
But I think those presentations are really helpful, both of you. Thank you, guys. I think one of the key things I also learned was travel. I always have the habit of writing, $1,000 1 year, done, for 3 years, and then never think about it. But I think you brought up some key points in a way that it has to be, laid out, thought through in detail, so people know that you thought through that. So thank you for that.
You're welcome.
Well, we'll end this here.